Hello, I am Melissa Ehlers. I'm a pediatric anesthesiologist and I am director of the residency program at Albany Medical Center. Thank you for watching our video, and over the next 40 minutes I will give you a preview of what our program is all about. I will briefly talk about the hospital, our department, what our personnel structure is like, and then delve into the program didactics, what our graduates are doing, and how we do with accreditation with the ABA. Here in this picture, you see the Saratoga Performing Arts Center in the background. This is where Albany Medical College graduates out of each spring. It's a beautiful venue, usually ranked number 1 or 2 in the country as far as venues for wonderful musical acts that come here, as well as the opera, ballet, and the orchestra during the summer months. Our medical college was founded back in 1839, and the hospital was founded in 1849. Neither of these two structures stand. However, they were moved to the present site sometime in the late 1800s. And in 1982, Albany Medical Center was established, incorporating both of them. We have one kind of long building, so we are physically connected to the college, which affords us many opportunities to integrate more closely with the students as well as their faculty and have easy access to their library. In 1999, a small hospital 2 blocks away was acquired, which we formed into our South Clinical Campus, and that is a site where we have 8 additional mostly ambulatory surgical beds. Our institution has been lucky enough to be growing. We have incorporated into the Albany Med Health System Columbia Memorial Health, which is located about an hour and a half to our south, Glens Falls Hospital, located an hour to our north, and Saratoga Hospital, which is located about half an hour to our north. Because we are affiliated with these other hospitals, it improves our buying power and gives us leverage with the reimbursement factors from insurance companies in the local area. Currently, we do not have any of our residents rotate to these other locations. However, possibly in the future, several years down the road, that might be a possibility if it was felt to be advantageous to the program. In this aerial shot, you get a view of the whole campus of Albany Medical Center. You can see the college up in the top part of the picture. You can see the Masry Family Children's Emergency Room off to the right, as well as the Adult Emergency Department. Down below that, slightly to the left, is the Patient Pavilion. And some of those windows in there are actually windows outside of our operating rooms, which means that yes, we do get to see daylight during the day, which can be very helpful to our wellness, I think, being able to see outside. In addition, you can see that there are several flyovers over the street that afford us an ability to get over to the parking garages, as well as to Panera and Starbucks, without having to really step foot outside, which can be helpful during the winter months. Albany Med is a relatively large campus. We have, as you can see, 766 licensed beds, and we performed in 2019 over 30,000 surgical cases. So there are plenty of cases for you to learn and hone your skills on. We employ just shy of 10,000 employees, and it was recently pointed out that we are almost the size of Vatican City, so almost the size of a small country, which is crazy. We have the Bernard and Millie Duker Children's Hospital within Albany Medical Center on a couple of the floors. We do all sorts of different cases here, cardiac, we have congenital hearts, we have all surgical subspecialties represented. High-risk OB abounds here, and we are the busiest level 1 trauma center in New York State. In 2013, we moved into our new OR and ICU tower. They have 20 new OR operating rooms in B building, as well as another 15 in the C building, for a total of 35 ORs that we are running on any one day. In addition, there is a brand new PACU on both of those floors, and 2 new ICUs, a new SICU and a new neonatal ICU. This is an example of what all of the new ORs look like. They all would include a standard anesthesia machine, so once you learn one machine, that's all you need to know for all the other ORs. An anesthesia cart, which is standardized throughout the institution, so anywhere you go to do an anesthetic, you'd find everything in the same exact drawer. And a Pyxis, which can be found in each operating room. This makes it incredibly convenient for you to be able to remove a wide array of narcotics, controlled substances. All the drugs that you need to provide your anesthetics are usually contained within that Pyxis, and it allows you to waste those drugs with any licensed provider at will. In addition, you can see the surgical boom, which has a plug-in for Stort's equipment, so we can use that when we are utilizing teaching laryngoscopes, for instance, and there are multiple overhead screens so that we can easily view the surgical field when laparoscopic procedures are being done. This is an example of one of the PACUs, and more specifically, this is the pediatric PACU, which you can tell by the fish on the floor, as well as floating up around the ceiling, and at the bedside of each pediatric PACU bay is a rocking chair for the parent of the patient to get comfortable in while they're waiting for their child to wake up. Albany Medical Center serves approximately 25 counties. You can see in orange, those are the nearby counties where patients might be coming to us for simpler procedures like hernias, things like that. Once you get up to the green areas, that's more of our tertiary service area. So there are small hospitals located in those areas, but those hospitals don't have all surgical subspecialties represented. So therefore, patients may be traveling from those counties down to Albany Med for specific care. As you can see, we also extend into Bennington County in Vermont and then Berkshire County in Massachusetts. Additionally, we frequently see patients actually from Pennsylvania who may come up here for care as well. Our department currently has 65 faculty. We take 6 residents per year, and we have 58 nurse anesthetists, many of whom are part-time, as well as a student nurse anesthesia school here, which has approximately 25 members per class and helps as a feeder to provide us with nurse anesthetists when they graduate. Most of those student nurse anesthetists do their rotations at outside institutions. So at any one time, there typically are only 4 or 5 of them rotating here at Albany Med. We have a wonderful group of perfusionists, super anesthesia techs, approximately 14 in number, who provide wonderful support so that you're not stuck doing a lot of room turnovers or having to find a lot of equipment. Instead, they can be doing that while you're concentrating on the patient. And we have a fantastic administrative support and billing staff who will make sure that all of your proper documentation gets submitted in a timely manner and you're not having to run around and find some notes 3 days later. As you probably all know, we are a 4-year categorical program with a clinical base year included, and again, we take 6 residents per year. During your clinical base year, which we have specifically built to complement our anesthesia program here, you can expect to do 5 months of internal medicine, and that may include up to 1.5 months of night float, sometimes at the VA, which is directly across the street from us, but more so at Albany Med. You may do, and you do also go to the medical ICU and the coronary care unit for 1 month, and those rotations have proven to be very educational for our interns. In addition, you do 1 month pediatric specialty inpatient. Typically that is on the HEMOG service, where you get to care for some really sick kids, and they have wonderful teachers on that service. 1 month in the pediatric ICU. Again, a great opportunity to see children coming back from congenital heart surgery, as well as kids presenting with a wide host of various conditions that need to be treated. We are the only PICU in the surrounding 26 counties, so pretty much all sick kids would be coming our way. In addition, 1 month of emergency medicine. We try to find you 2 weeks to do research within our department, 1 week typically in the first 6 months so that you can get a project started, another week in the second 6 months so that you have time to further work on it, maybe recruit patients if it's prospective, or do data collection if it's retrospective. Also a 1 week QI project, and then 1 to 2 weeks of elective time. In addition, somewhere in there you'll do 2 weeks of a preoperative assessment clinic and 6 weeks of enhanced recovery after surgery. This has proven to be a very popular rotation. During that time, you will be interfacing with a couple nurse practitioners who do the bulk of the rounding on the patients. You will, however, be participating with seeing the patients before their surgery, helping to set expectations, counseling them on what the particular pathway we're going to use for pain control during the procedure. And you typically get to place a lot of blocks. Actually most of our interns have finished their intern year with over 100 blocks under their belts already. And since you only need 20 to graduate, that is a pretty considerable number. And then finally, of course, 1 month of vacation is given during your intern year. During your clinical base year, we highly encourage you whenever possible to attend the afternoon lectures that are given every Monday at 3 p.m. to our CA1s. Those lectures are aimed at passing the basic exam. We provide you with textbooks early on during your intern year where they may be helpful on some of your rotations. We encourage you to attend journal clubs whenever you're able to, and also come to the quarterly dinner meetings, which are at local restaurants when District 4 of the New York State Society of Anesthesia meets. In addition, we hope to foster a collaborative early relationship with you through your interaction with us during your ERS rotations, as well as pre-op research, QI, and any elective pain rotations that you may take with us. Here is a slide of our happy residents having lecture in the lecture hall. Our onboarding process takes place currently during June and July, starting at the end of intern year and going into CA1 year. That very first week will be all lectures to get everybody up to speed, but following that you will be in the OR assigned with another resident typically, or one-on-one with an attending, except for Thursdays, where you will have continue to have a full day of Thursday lectures. Starting after the fourth week, you will have call responsibilities where you will be taking 8 p.m. call. Then 4 weeks after that, you will be taking overnight call, which is about mid-August. So at that 4-week mark, that is also when you will now be potentially solo, obviously with attending supervision, but they may have a second room, and that is typically accomplished by around July 7th. We use the anesthesia knowledge test, as do most other anesthesia programs, and this is a national standardized test which allows you to compare how you are progressing against other residents at your level throughout the rest of the country. It's a great way of making sure that you are on track to pass both your basic exam and then your advanced exam after graduation. The first test is given the very first day of CA 1 year, and then the second test is taken approximately 2 months later, another one at the 6-month mark, again at the 24-month mark at the end of June of your CA 2 year. The rest of CA 1 year, once you get through the introductory course, consists of 3 more months of being in general OR type cases. Again, sometimes those can be fairly complex cases because we have a lot of sick patients coming even for a lap chole, but the patient may have a hypertrophic cardiomyopathy or other things going on. So you will be challenged during those 3 months. Then you're going to start your subspecialty rotations starting in November or December. And we do this because we feel it's really important for you to get exposure so that you can have some idea if you want to do a fellowship, which you typically need to apply for during your CA 2 year. So you'll do an airway rotation, you'll do a month of cardiac, month of SICU, OB, neuroanesthesia, pediatric anesthesia, and regional/acute pain. This is an example of what one of those schedules would look like. Dr. Laufer, one of our pain docs, is also an amateur photographer, and he took this beautiful picture one day in, I believe, one of the thoracic rooms, and this is a former resident who now practices in private practice just down the street. Quick review that the ABA has a staged examination system, and you do have the advantage that both the chair, Dr. Jones, and myself are both senior board examiners, so we are intimately acquainted with all the details of what the applied exam entails and get frequent updates on any changes that are happening to the basic or advanced exams. And of course, the basic exam is the first high stakes exam that you'll take at the end of your CA 1 year. It is a must-pass exam for you to be able to advance further and graduate. As its name implies, it prepares you or tests you on basic things: pharmacology, physiology, anatomy, anesthesia equipment, and basic monitoring, versus the advanced exam, which will focus more on subspecialty type topics. The basic exam started in August 2014. Again, this is what our Monday afternoon basic science curriculum is aimed at, to get you ready to take this test in the end of your CA 1 year. And here is one of our lecturers lecturing to the CA 1s. The didactics for all of the residents starts in August. Typically during the month of August, it is actually led by the chief residents. They then run through the end of June. They are currently on Thursday afternoons from 1 to 4 p.m. in protected time that you get relieved from your rooms to go to. Based on feedback from former residents, we have broken them into first a general and then subspecialty blocks, which means that you will get a combination of lectures, PBLDs, mock orals, journal clubs that are all based on the block that you currently are in. For instance, cardiac versus pediatrics versus OB. We encourage a flipped classroom wherever possible, again using PBLD type format, questions, using available question banks, because our residents have given us the feedback that they find that much more helpful and interactive. and we try to, whenever possible, correlate it with Anesthesia Toolbox, which is a wonderful online tool we have purchased for all of our residents, has its own question bank, has multiple podcasts, a curriculum that we use in many of our rotations. So we really try to surround you with many, many different modes of learning that you can use for your didactic schedule. Here is a sample of how our didactic schedule runs. Typically, we do general anesthesia topics for the first month, segue to cardiac, then ICU, regional, some ITE review right before you take the in-training exam, and then go to OR, peds, PACU, neuro, thoracic, chronic pain, so that we cover basically all of the subspecialty areas that need to be covered. Here is our auditorium that we use for grand rounds. Grand rounds occurs every Thursday morning from 7 to 8 a.m. This is protected time when the ORs are not running. Typically, the first Thursday of the month is a business meeting where the residents would meet in your resident room with your chiefs. It's an opportunity to discuss any issues that are coming up, and any problems that you foresee. Things that need to be brought back to me can be brought back at that point, and usually I have discussion topics for the residents to talk about as well. But then the other 2 or 3 weeks are usually filled with people who are coming from outside the institution or inside the institution to talk about various topics. And then, of course, M&M is usually one of the Thursdays of each month. Journal Club is done on an approximately monthly basis. We do a dissection of the statistical methods used, since there is a fair amount of statistics on your basic exam and on your advanced exam. Dr. Silverman, who is head of our acute pain rotation, is wonderful at delving into this, and 2 residents will take turns presenting this critical review of the literature. During CA2 year, you can expect to move on to slightly more difficult rotations. You'll do actually now a full month of PACU, which is also integrated with that half month of focused transthoracic echo. Then another repeat of neuro, cardiac, SICU, a month of vascular. We have a very active vascular service. You get to do a month of chronic pain here, and then another month of acute pain, regional, also 2 months of thoracic, a month of pediatrics, and a month of OB again. This is an example of a master schedule, again showing those rotations. Here is a picture of one of our chief residents performing a block. He went on to do a PEDS fellowship out in Arizona and is currently practicing at a children's hospital in Colorado. During your CA3 year, you have only 4 months of required rotations. Those are a half month of NORA, or non-OR anesthesia, where you would get much more familiarity with the GI suites, EP type cases, cath lab, and VIR type cases, and possibly get experiences where you actually get to help run multiple rooms, and so kind of as a mini attending experience. Also, a half month of ortho had been requested by previous residents, just to get additional experience, maybe running 2 busy OR rooms, orthopedic OR rooms. Then you do need to do 2 months of advanced OR, or AOR, and those are the months where you get yet another opportunity to do some advanced type cases like pheochromocytomas, advanced vascular cases, advanced pediatric and OB cases, depending on what you are going into. And again, just fill out any areas where you think that you would appreciate a little bit of extra experience in. And then we do require 1 month of what we call our PET rotation, which is a combination of PACU, echo, and trauma. Other than that, the remaining 6 months, you can choose from this long list of electives. Most people choose to do at least 1 more month of OB, perhaps a month of cardiac, a month of peds, and 1 to 2 months of regional. But then you can see the other options are to do some more chronic pain, to do some more echo and research time, go over to our ambulatory surgery center and do a month there, go across the street to the VA if you would like to do a month there. Some people have done time in our cardiothoracic ICU or in our pediatric ICU or the SICU, and really we're pretty open to you designing your own electives based on where you think you will be practicing after graduation. Here's a quick look at a case log total from one of our residents. As you can see, the numbers in blue are the required minimums and the total are over here in red. So this resident was well above the required minimum on these cases. And then you'll note here their total peripheral nerve blocks are in the 400 range. I'd say that most of our residents actually now are graduating with over 500 blocks, sometimes in the 600 range. So you will definitely be very comfortable with them. Coming for 2022, we try to always have something new and be trying to improve things wherever we can. Continued expansion of the transthoracic echo pathways, going up to codes and being able to do quick echoes during the 10-second pulse check has been, in some cases, life-saving for patients. We also hope to increase our number of perioperative surgical home or ERAS pathways that we are currently servicing. This has been very well received by the administration and by our surgeons because it is definitely seen as an improvement in patient care as well as ways to help improve throughput for the hospital. We will be continuing with our systems-based practice week and then research week and holiday, which is our way of being able to get you off as an intern out of the other services and give you 3 weeks of no call and have you here within our department, as well as get you some time off for the holidays if you would like to take your vacation time there. We are always continuing to further develop our wellness curriculum and coming up with fun activities for the residents to do, as well as teaching, about lifestyle choices that would benefit everybody in the long run. We are continuing with our oral board review sessions and trying to make those as helpful and friendly as possible. And then also we have implemented some research/wellness mornings where you can find time along with the chiefs that you get assigned where you would have the mornings off to go do doctor's appointments and get your car fixed, whatever you need to do during normal business hours that it's frequently very difficult to get to. We do offer some international/mission opportunities. We have had residents travel to Peru, Haiti, Ecuador, Guatemala, and Mexico, along with staff from Albany Med, where they provide care to people there, typically with surgeons from other organizations. This is an opportunity that you can take advantage of only during your CA3 year. Our Clinical Competency Committee, or the CCC committee, meets on a quarterly basis, and the purpose of this is for us to review all of your evaluations and make sure that we are effectively giving you feedback, so that if there are any issues we see with your future competency, we want to give you immediate feedback right away and help you come up with a individualized plan in order to remediate any issues that we see. For academics projects, we do require you to give at least one grand rounds to our department during your CA3 year and do at least one poster presentation. Because we pay for you to go to any meeting at which you're presenting a poster, this typically, most of our residents, I would say, graduate with about 5 to 8 posters under their belt, which they're able to put on their CV. In addition, we talked about the fact that you do need to do a QI project both during intern year and then another one, at least one, during your CA 1 through 3 years, and you'll give a short presentation on that during your CA 3 at the end of the year. Participation in M&M, of course, is required, as well as occasional lecture PBLD assignments, and you're required to participate and be a presenter in 1 journal club per year. We provide formal oral exam practice for both the CA2s and 3s during one morning in February, typically, where you actually dress up like you're going to the oral boards, and so do the attendings, and take you through an actual oral board step. In addition, we also do a simulation of the OSCE part of the applied exam, so that you get practice on that before you go there for the first time. We have a beautiful simulation center where you can see through this glass pane. Here is an OR that is set up to mock our ORs, and we run simulations here typically about once a month, if not more frequently, for the residents. There is a TEE simulator over there in that simulation area. So what do you really want to know? Some of the nuts and bolts of our program. As far as call team, there are 2 attending anesthesiologists in-house at all times. We also have 1 resident plus 2 to 3 nurse anesthetists to cover the 4 ORs, which can be running simultaneously on a really busy night. In addition, up in OB, we would have either a resident or a nurse anesthetist covering up there. Monday through Friday, we have a resident covering the ORs late until 8 p.m. typically. In addition, we have many CRNAs working swing shifts so that there are extra people around to help relieve people around 4:30 so that they can get home on time. If needed, we have backup attendings for both cardiac and pediatrics that will come in from home. Resident call hours, we have made every effort to keep them quite reasonable here. On average, our queue is about Q6, so you would expect to take 2 to 4 calls per month. Our call is for a 24-hour call, and you have the next day off. And you would have 1 to 2 8 p.m. Late person shifts per month as well. Our residents average about 50 to 55 hours per week, and rarely would be any higher than that unless you are doing moonlighting, which you do get paid for, but does contribute to call hours. Displayed on this slide, you can see the 2021 to 2022 salaries here at Albany Medical Center. In general, the salaries increase about $500 or so per year, so you can expect to add that and market adjustment per year that you move through the residency program. As far as leave and conference time, the ABA mandates that you only get 20 days per year, which is 4 weeks off, and then an additional 5 days conference time. Discretionary money is on a graded basis. However, I will say we tend to take the money, pool it so that we can buy you all of your textbooks up front, which are very expensive. And then, as I mentioned, anytime you are going to a conference with a poster, we as a department take care of paying so that you can go to that conference. We also pay for you to take step 3 of the USMLE or of the COMLEX, but we will only pay for it if you take it during your clinical base year. We pay for your written board exam fee, or what we would now call the advanced exam fee, which you take at the end of residency, and we will pay for your first medical license. So that's a pretty significant chunk of change that comes due near the end of residency that we will take care of for you. In addition, we pay for your ACLS, your in-training exam fees, AKT fees, membership fees to the ASA and New York State Society, as well as the IARS. And we give you the TrueLearn and Anesthesia Toolbox online digital tools. We mentioned moonlighting opportunities, even during CA 1 year. If we are in need of extra people, we may consider buying back a few days of your vacation if you are interested in earning extra money. Otherwise, starting in the middle of CA 2 year, there are many Saturdays where we have extra shifts that we are willing to pay you for your coverage there. In addition, if you have to stay past 4:30 on any night to cover a room, we will pay you for that. Resident contract can be found at this URL. Everybody, of course, gets a criminal background check. On initial hire, a drug test is done, but then after that is only for cause. Where do our residents go afterwards? Many join the faculty. About 26 of our 62 faculty are former residents. About half go into private practice, and fellowships we have anywhere range from 3 to 5 out of the 6 go into a fellowship at any one year. Fellowships that we have here at Albany Med are a pain fellowship, which is under the neurology umbrella. However, the assistant program director is an anesthesiologist. We are hoping to get a critical care fellowship here for anesthesia in the very short term, and we do have a cardiothoracic fellowship here currently. In the past 15 years, our ABA board certification rate has been 95%, and many of our graduates are here in leadership positions locally. We have never had any issues with accreditation with the ACGME. Our last site visit was July of 2011. Only about a quarter of programs get 5 years, which is the maximum amount that you could get for accreditation, and we got that for the past 4 site visits before that. Now we are accredited annually, and we currently have a clean letter, meaning they don't see any issues with our program that they think that we need to address. And we will be having our next accreditation site visit in 2023. This is a map of New York State. As far as things to do in the area, besides all that Albany has to offer, we are a pretty quick drive or train ride, about 2.5 hours to New York City to the south, about 3 hours to the east to get to Boston, maybe 3.5 hours to the north to get to Montreal. So there is a lot to see and do, both in the Albany area, but also within a 3-hour radius. Lots of great hiking, water sports, skiing in this area. Here's one of our attendings hiking the Adirondack Peaks. And this is a winter view of some of those peaks. Dr. Green on our faculty is close to having finished all of the winter 46 peaks. Here's a picture of beautiful Saratoga Lake where I live. Wonderful water skiing, wakeboarding opportunities up there on that lake, and a great place to swim. A beautiful view from some of the mountains to the south, taken by one of our former chief residents. A tranquil pool, also shot by yet another chief resident when he took his family hiking and happened upon this. More pictures from this same resident. And a beautiful sunset up in the Adirondacks. Our residency class of 2019 is represented here. Because of COVID, we unfortunately could not have graduation for our 2020 grads, but we will be adding them into the 2021 graduation, which hopefully can be in person. Of these graduates, 2 went on to do chronic pain fellowships. 1 has since come back to join us as faculty here. 1 did a pediatrics fellowship and is now at a children's hospital down in North Carolina. 1 did a cardiothoracic fellowship, and he is now back in the area at a private institution. 1 of them joined us straight out of residency as attending staff, and the last one went straight into private practice. This picture is everybody added in. It really shows that it takes a community, not just the graduates, but their families, their support people, and then all of the attendings and ancillary staff that help support you as you go through your residency. And hopefully you'll come to feel that we're all part of your family as well by the end of residency. Finally, here are our interview staff. So you'll be meeting typically with 6 of these people during your interviews when you talk to us either virtually or in person. And hopefully you'll have a wonderful day talking to us and asking any additional questions you may have about our residency. Thank you for listening, and we hope to see you virtually.